Bismillah ar-Rahman ar-Rahim. We will discuss today a very important topic, theoretical and clinical, antepartum hemorrhage. الحقيقة any condition that could affect the general condition and expose the patient to a life-threatening situation is considered very important, even to the non-specialist, even to the doctors that will not specialize in obstetric and gynecology. Okay, because at the start of your practical life, you will be GP, general practitioner. So you should learn how to direct and deal with the critical situation. What's antepartum hemorrhage? Antepartum hemorrhage, any vaginal bleeding occur in the second trimester. Any vaginal bleeding occur in the second half of pregnancy from the time of fetal viability. This is a very important expression. You should know the fetal viability after 24 weeks. Okay? This is important in the definition of abortion, important in the definition of antepartum hemorrhage, fetal viability. So this is a common expression that you should be aware of. Any vaginal bleeding occur in the second half of pregnancy after fetal viability from 24 weeks onward up to 40 weeks. Most of these antepartum hemorrhage is maternal in origin, with the exception of only one situation we are going to tell later on. And in cases of severe antepartum hemorrhage, this will result in acute obstetric emergency, which is considered one of the triad of causes of obstetric causes for maternal death, including hypertension and complication, obstetric hemorrhage, and infection. So antepartum hemorrhage means bleeding from the vagina in the second half of pregnancy after fetal viability after 24 weeks onward. Most of condition, this bleeding is maternal in origin, with the exception of only one condition, which is Vasa Previa, in which bleeding is fetal in origin, and is considered one of the important triad of obstetric mortality and morbidity, in addition to hypertension and infection. What are the causes of antepartum hemorrhage? Causes of antepartum hemorrhage either causes related to the obstetric condition, or causes related to gynecological condition, or general cause. General cause, this could be applied to any individual pregnant women or non-pregnant women. Either therapeutic, intake of any drug that could result in bleeding as anticoagulant therapy, idiopathic thrombocytopenic purpura or other coagulopathy, severe hypertension, severe uncontrolled hypertension that could result in bleeding from anywhere in the body, abnormal liver function to the extent that it results in abnormal bleeding. What are the gynecological causes? Vaginal trauma, benign vaginal lesion as vaginal polyp, any vaginal ulcer, cervical cancer during pregnancy. There is a risk of cervical cancer occurring during pregnancy. Okay, so please, when you are asked about antepartum hemorrhage causes, we have gynecological cause, we have general causes, and then stress on our main topic, obstetric causes of antepartum hemorrhage. We have important three causes for this situation: placental abruption, placenta previa, and vasa previa. The most common cause of antepartum hemorrhage is placenta previa, followed by placental abruption, and then the very rare condition, which is vasa previa, in which the bleeding is fetal in origin, as we will tell. What is meant by placenta previa? Placenta previa is defined as antepartum hemorrhage after fetal viability in the second half of pregnancy from abnormally located placenta, from abnormally implanted placenta, from abnormally situated placenta. So placenta previa is a condition in which there is abnormal implantation of the placenta over the lower uterine segment, and according to the relation of the placenta to the internal cervical os, it is classified into different types. So placenta previa means abnormal implantation of the placenta over the lower uterine segment, And this usually manifested by antepartum hemorrhage after fetal viability in the second half of pregnancy, and according to its relation to the internal cervical os, it is classified into different types. Again, here this graph demonstrates what's placenta previa, a condition in which the patient may develop antepartum hemorrhage with abnormal situation or abnormal implantation of the placenta over the lower uterine segment, and usually the patient presented by bleeding after 20 weeks gestation. As we mentioned before, it's one of the most important causes of maternal and fetal morbidity and mortality. What is the incidence of placenta previa? It was found that in all pregnancies, this abnormal located placenta represent 0.5%. 0.5% of all pregnant women will show placenta previa, and 20% of causes of late obstetric hemorrhage. So it's present in 0.5% of all pregnancies and account for 20% of all causes of antepartum hemorrhage or late obstetric hemorrhage. The most common cause of antepartum hemorrhage is placenta previa, 20% of late obstetric hemorrhage. Why the instance of placenta previa rise in the last 2 decades? You know, decade means 10 years. In the last 20 years, why the instance of placenta previa increase? Because of advancement of maternal age and increased repeated cesarean section. Why repeated cesarean section increase the risk of abnormally implanted placenta? You know, cesarean section and the healing of the scar inside the uterus, whether it is cesarean section scar, whether it is myomectomy scar, usually leave fibrous tissue. And the fibrous tissue may produce insufficient decidual reaction for implantation. And so these result in the placenta or the embryo for implantation search for a suitable place. That's why repeated cesarean section with repeated scarring of the endometrium may provide unsuitable environment for the implanted embryo, which may result in ectopic or abnormal implantation of the fertilized ovum. So the risk increases with advancement of age and with repeated cesarean section. What are the risk factors increasing the incidence of placenta previa? Advancement of maternal age. This woman is old, as you see, more than 35. About this is more than 60 actually. So advancement of the maternal age. Low socioeconomic standard. Why? Because low socioeconomic standard usually show multiparity. Count 1, 2, 3, 4, 5, 6, 7. Multiparity. Short inter-pregnancy period. Recurrent, usually associated with recurrent abortion, multiple gestation. So advancement of maternal age, increase our low socioeconomic standard because of the possibility of other risks as multiparity, short inter-pregnancy spacing, recurrent abortion, multiple gestation. Following infertility treatment due to the possibility of associated abnormal endometrium, whatever, due to previous scar, previous operation, associated adenomyosis, whatever. Previous uterine scar, yes, increase the risk of placenta previa. Smoking, erythroplastosis, RH incompatibility, non-white ethnicity, and cocaine use. These are accidental cocaine use, and non-white ethnicity is accidental increased instance. Why placenta previa could result in repeated attack of antepartum hemorrhage? What is the mechanism of bleeding in case of placenta previa? You should understand that there is a lower uterine segment which develops from a very small part in the uterus called isthmus. You remember from the anatomy, the isthmus, this is the uterus, and this is the cervix. This is the body of the uterus. And here is the isthmus. The isthmus equals 0.5 centimeter, equals 5 millimeter. And this is the isthmus during the second half of pregnancy. start to form the lower uterine segment. And so during this time of the formation of the lower uterine segment with possibility of implantation of the placenta over that lower uterine segment, these result in unavoidable separation of the placenta during gradual formation of the lower uterine segment, and this sharing movement of the placenta secondary to development of the lower uterine segment result in unavoidable separation of the placenta. And this unavoidable separation will result in repeated, recurrent, causeless, painless uterine vaginal bleeding. Why it is recurrent? Because it is associated with the sharing movement of the placenta during the formation of the lower uterine segment that occurs gradually. Why it is spontaneous? Because it is not induced, it's a continuous process that occurs during the second half of pregnancy. Why it is painless? Because it is not associated with uterine contraction. But if the patient suddenly develops uterine contraction, this separation of the placenta will occur all of a sudden and will result in rapid separation with sudden severe bleeding. Okay, so these gradual, recurrent, causeless, painless, spontaneous bleeding, which are the characteristic symptoms in patients with antepartum hemorrhage due to placenta previa, may change to be associated with pain and may be severe if it is associated with onset of uterine contractions. The lower the placental implantation over the lower uterine segment, the more it will be affected by the sharing movement and unavoidable separation, and so the more severe pattern of vaginal bleeding. We mentioned that according to the relation of the placenta to the internal os, it is classified into different types. If the placenta completely, this is the internal os and this is the placenta. If the placenta completely covers the internal os, so this is total placenta previa. If the placenta partially covers the internal os, it covers it but partially, this is partial placenta previa. If the lower edge of the placenta is very close to the internal os, of a distance of less than 2 centimeters, this is marginal placenta previa. And it's one type as well. Other classification, they said that total and partial are called major placenta previa, while marginal and low-lying placenta are called minor placenta previa. And this classification is based on the severity of the expected severity of bleeding from which this patient could suffer. The same. Yes, this is the classification we said: major placenta previa, minor placenta previa, major placenta previa including the complete, when the placenta completely covered the internal os, or the partial, when the placenta partially covered the internal os, and minor includes marginal, the lower edge of the placenta very close to the internal os by a distance of less than 2 centimeters, or low-lying placenta where the placenta is close to the internal os but more than 2 centimeters from the internal os. Clinical presentation. How my patient with placenta previa could be presented? As we mentioned, the triad specific for a case of placenta previa. The patient presented by vaginal bleeding, which is characteristically recurrent, painless, and causeless. This is the classic typical presentation of placenta previa. Recurrent, painless, causeless vaginal bleeding. These symptoms are not present in 1/3 of cases. 1/3 of cases will not suffer from this presentation and may be discovered accidentally during routine antenatal care on performing abdominal ultrasound. But the remaining cases, 2/3, will be presented by the classic presentation as we mentioned before. What about the examination? According to the severity of bleeding, according to the general condition of the patient, mild antepartum hemorrhage, there will be no significant general signs apart from pallor, mild anemia, mild palpitation, and tachycardia. Severe antepartum hemorrhage, the patient may be presented by shock according to the amount of the revealed vaginal bleeding. Abdominal examination may show malpresentation common due to occupying the lower uterine segment by the placenta. Usually these condition or this patient may have malpresentation. Local examination should not be done. Forbidden. Never do vaginal examination in a patient with placenta previa because you may provoke or initiate severe uncontrolled vaginal bleeding. Okay? So per-vaginal examination should never be attempted when you are facing a patient with antepartum hemorrhage, just according to the general condition of the patient. If it is okay and there is no manifestation of hypovolemic shock, take your patient to the ultrasound room and confirm the position of the placenta. Where the placenta? If the placenta is low-lying or implanted over the lower uterine segment, never do bare vaginal examination. It is forbidden, and you should tell your patient or demarcate this patient no BV. Ultrasound diagnosis, which is the gold standard for diagnosing of cases of placenta previa. This is the cervix. This is the cervix, this is the placenta. According to the relation between the placenta and the internal os, you will identify the type of the placenta. Again, here, this is a transvaginal ultrasound. The cervix is clear here. This is the cervix, and this is the lower edge of the placenta, the partial placenta previa or major placenta previa. This complete placenta previa, the placenta completely covered the internal os. Again, this is major placenta. Both conditions are major placenta previa actually. Again, here, this is the presenting part. The presenting part, this is the placenta. And this is internal os, a case of placenta previa major or complete centralis. Here we do the same situation, the cervix and the placenta. Okay, what are the complications of this clinical situation? Are there any expected complication for placenta previa? Yes. For maternal complication, the mother may suffer from, due to the repeated recurrent attack of vaginal bleeding, may develop anemia in mild situation. Or in cases of severe bleeding, severe antepartum hemorrhage, it may pass into hypovolemic shock, and if the condition was not properly corrected, the patient may pass into DIC or disseminated intravascular coagulopathy. So, antepartum, the patient could be presented by either alcohol complaining of anemia, complicated by anemia, or hypovolemic shock and DIC in severe antepartum hemorrhage. Any anemic patient, as a rule, is exposed to postpartum hemorrhage because of hypooxygenation of the myometrial muscle that result in weak contraction and consequently may interfere with proper control of bleeding after separation of the placenta. So there is a risk of postpartum hemorrhage. In case of severe vaginal bleeding that could be uncontrolled, or if the patient passes into severe atony that could be uncontrolled, we may pass into Cesarean hysterectomy, so the patient may lose her uterus. In cases of placenta previa, especially with the presence of uterine scar, there may be a possibility of abnormal implantation, abnormal invasion, abnormal attachment of the placenta to the underlying myometrium. You know, under normal situation and normal implantation, there should be a usual plane of cleavage between the placenta and the underlying myometrium, the corium frondosum and deciduum apisalis. This is the usual line of separation. Sometimes the corium frondosum advances more into the decidua, into the wall of the myometrium, and this abnormal adhesion interfere with the proper normal separation of the placenta that occurred during the third stage after expulsion of the fetus, and in this condition the patient is present at a great morbidity, may develop may need cesarean hysterectomy, and if the condition was not properly and early managed, she may alter her condition and result in loss of the patient life. So it is a very critical situation that needs to be properly assessed and properly diagnosed and properly predicted. Very important. Early prediction equals proper management. Early diagnosis equals proper management. Even if there is a great problem, even if we have a major problem, once you get ready, once you identify your potentiality, your capabilities, and prepare or arrange the situation according to the need, it will pass. Everything will be okay, inshallah. What about the fetal complication? There is increased perinatal morbidity and mortality due to possibility of prematurity, IUGR, even intrauterine fetal death from the massive blood loss. You should prepare according to your potentiality and situation. Management of antepartum hemorrhage due to placenta previa. Actually, there are three important conditions upon which we classify the two lines of management. If the patient is present in a severe attack of bleeding, if the patient, the bleeding affects the general condition of the patient, if the fetus is distressed or not, or calm, also the duration of gestation, and if the patient is in labor or not. So we have three important parameters: severity of antepartum hemorrhage, the maternal and fetal condition are very important, the general condition of the mother and the fetal well-being, gestational age at the time of diagnosis, if the baby is mature or not, and the presence or absence of uterine contractions. So these are the most important three situations upon which I'm going to put my plan. My patient is in labor or not. My patient has severe bleeding or not. My baby is well-being or compromised. The fetus is compromised or not, and the duration of gestation, if the lung mature or not. Again, this line demonstrates if the patient's contraction or not, the duration, gestational age of the fetus, and the condition of fetal well-being, and according to the presence or absence of vaginal bleeding, and if it is severe, severity and the presence of vaginal bleeding. What are the two lines of management in such a case? We have expectant or conservative management. I'm going to wait. Continuation of pregnancy or termination of pregnancy, active management. If we have the patient with no vaginal bleeding and the patient not in labor, general condition of the mother is okay, general condition of the fetus and the fetal well-being is okay, so I'm going to continue my pregnancy. If the duration of gestation is not yet till mature, below 36 weeks gestation. So we are going to do hospitalization of the patient, bed rest, full labs of the patient will be done. And if my patient has any abnormalities, it should be corrected, especially anemia. If my patient has anemia, you should do rapid correction, even by blood transfusion. So hospitalization, bed rest, full laboratory investigation, correction of any anemia or any abnormalities that could be present in my patient, blood preservation. You should prepare blood for this patient. She may experience severe attack of vaginal bleeding at 2 p.m. or 5 p.m. where there's nothing there. Nobody there can help her or bring blood for her. So blood reservation that should be kept in a certain situation to be renewed, يتجدد every 48 hours. كل 48 ساعة تحجز من العيانة دي وتكتب عليه يجدد كل 48 ساعة. Okay. Close observation of the mother. Evaluation of the fetal well-being at regular basis, daily evaluation of the fetal well-being, because the fetus of a placenta previa is prone to IUGR and prone to abnormal or to any complication. And if the mother is Rh negative, you should give the anti-D immunoglobulin if the mother is known to be Rh negative. On the other side, if the patient has contraction, if the patient has considerable vaginal bleeding, if there is deterioration of the intrauterine fetal condition, or if the patient is in labor, termination of pregnancy, usually by cesarean section, placenta previa. When to do vaginal delivery, the trial for vaginal delivery could be there in cases of low-lying placenta if the lower edge of the placenta is away from the internal os by more than 2 centimeters with minimal vaginal bleeding, with close maternal and fetal monitoring. You should ready for this patient to transfer her or to change your decision at any time if the condition necessitates into immediate cesarean section, and you should counsel and consent to the patient that this is a trial, we can fail at any time, and change the decision to cesarean section. So the main line of treatment, either expectant, continuation of pregnancy under certain situation, and these are the lines of treatment that should be followed, or active termination of pregnancy when it is indicated, usually by cesarean section, and only one strict indication for trial for vaginal delivery under these special important precautions. Again, this diagram summarize the line of treatment: patient with severe bleeding, immediate resuscitation, and termination by cesarean section. Moderate vaginal bleeding according to the duration of gestation. If my patient is above 34 weeks and the patient has moderate vaginal bleeding, immediate cesarean section. If the patient is below 34 weeks, we can resuscitate the patient if we can and give her corticosteroid to increase the chance of postnatal survival and improve lung maturity. And then if the patient got stable after resuscitation, it's okay, conserve till 36 weeks. If the patient not and remain unstable after resuscitation, transform her into immediate termination by cesarean section. If the patient has mild bleeding and the duration of gestation is above 36 weeks, usually we terminate. We can give corticosteroid and terminate. Less than 36 weeks, do conservative management as we mentioned before. Okay, very important topic. A very important topic. Placenta previa is one of the most important critical situation that you should be aware of. The second common cause of antepartum hemorrhage is accidental hemorrhage. Again, this is very important as well. It is a critical situation. What is meant by accidental hemorrhage or placental abruption? It is a condition of bleeding in the second half of pregnancy, which with a normally implanted placenta, and it is due to separation of a normally implanted placenta. So, this bleeding in the second half of pregnancy, due to separation of a normally implanted placenta over the upper uterine segment. You know that placenta is implanted in the upper uterine segment in 98% of cases. This is the normal or the usual implantation of the placenta. And the remaining 2% could implant it elsewhere. 0.5% it is implanted over the lower uterine segment. Okay, so this condition represent 1% of all pregnancies, and this is the second most common cause of antepartum hemorrhage. It's very critical. What are the risk factors for antepartum hemorrhage? These summarize or help you to memorize risk factors for antepartum hemorrhage who make the placenta separate antepartum, who cause separation of the placenta from its normal implanted antepartum. We have obstetric causes and non-obstetric causes. The non-obstetric cause, advancement of maternal age. It was found these old age women, when got pregnant, may be due to fibrosis of the myometrium, abnormal implantation of the myometrium, inavoidable separation of the placenta. Case with thrombophilia may be due to the autoantibodies and some abnormalities. Smoking and cocaine use also increase the risk of accidental hemorrhage and separation of a normally implanted placenta. Trauma, طبعا, is one of the most important causes. What are the obstetric causes? Polyhydramnios, with sudden rupture of membrane, which results in sudden reduction of the intrauterine pressure followed by separation of the placenta. Prolonged period of rupture of membrane, gestational hypertension, severe gestational hypertension may be complicated by separation of the placenta. Chorioamnionitis also may be complicated by accidental hemorrhage, and the multipara are more prone to suffer from separation of abnormally implanted placenta. Progression of placental abruption. The condition may start with a small hematoma that may not be diagnosed properly or seen during abdominal ultrasound, and then gradually the bleeding extends to separate the placenta completely from the underlying myometry. What are the types and nature of bleeding in cases of accidental hemorrhage? Either the bleeding comes to the outside, it's called revealed accidental hemorrhage, or collect inside the uterus between the separated placenta and the myometrium, and here in such condition it is concealed, hidden. It is not seen to the outside, not identified by the patient or by the doctor. May be seen by ultrasound, but clinically it's not revealed. There is no external bleeding. Or mixed, concealed and revealed. Some remain inside separating the placenta, and again it is come out through the internal os. Again, these demonstrate how the placenta is separated and the blood collected between the placenta and the overlying myometrium. What about the clinical presentation? You remember the patient with placenta previa was characterized by a triad of symptoms: painless, causeless, recurrent attack of vaginal bleeding. But here the bleeding is painful. Usually there is pain. Usually bleeding may be initiated by trauma, may be initiated by uterine contraction, associated with uterine contraction. The patient may be hypertensive, so it is induced. It is not causeless. It is induced by a cause. If there is pain, there is associated factor, and usually there are other situations, other conditions. The uterus is tender, the patient is in problem. So it is not the same as in cases of placenta previa. In cases of revealed bleeding, the patient presented by vaginal bleeding, which may be mild or severe. If it is mild, usually there is only bleeding, okay, with or without severe abdominal pain or mild abdominal pain. So there is pain and the bleeding in cases of revealed accidental hemorrhage. If it is concealed, usually there is no bleeding, but usually there is pain and maybe fetal distress. So in case of accidental hemorrhage, almost always there is pain, whether it is revealed or concealed. If it is revealed, there may be bleeding, mild or moderate. Concealed, usually there is no bleeding, but usually there is fetal distress. And you may be worried why the fetus is distressed and the patient in pain. Okay, and when we perform ultrasound, you can demonstrate the collected blood between the placenta and the myometrium. Mixed, there is pain and bleeding together with or without fetal distress during performing or auscultation of the fetal heart sound. So the symptoms and signs according to the type: revealed, there is bleeding and pain; concealed, there is pain but no bleeding, but usually there is associated fetal distress; mixed, according to the situation, both conditions may be there. General examination of the patient. Actually, this is not a pregnant patient. This is a patient with hypovolemic shock. It is not a pregnant patient. General examination according to the type of bleeding and according to the severity of bleeding. If it is mild bleeding, usually the general condition of the patient is okay. If it is severe, usually the patient is affected and may pass into hypovolemic shock. This is the general examination. Abdominal examination, usually the uterus is tender and painful. There may be higher fundal level than the duration of gestation because of the collected blood inside, especially if the condition is concealed without being revealed. Fetal heart sounds may be inaudible, may be distressed, may be normal according to the degree of separation of the placenta. So usually there is tenderness, there is uterine pain, there is rising fundal level, which may be higher than the duration of gestation, and the fetal heart rate may be inaudible, bradycardic, or shows any abnormalities. Vaginal bleeding performed only after exclusion of placenta previa. Once you find this condition, immediate resuscitation if the patient has hypovolemic shock, and transfer to the patient to the emergency room, to the operation room, and bring the ultrasound in the operation room, perform a transabdominal ultrasound to exclude placenta previa. At the time, you can examine your patient and detect the condition of the cervix, because patient with accidental hemorrhage may be delivered vaginal, which is better for the patient if the condition allows, as we will say later on. So, general examination according to the degree of bleeding, abdominal examination, and vaginal examination after exclusion of placenta previa. Ultrasound should be done, and the importance here of ultrasound to exclude placenta previa, okay, and to detect the retroplacental hematoma, which may or may not be detected. Sometimes it is mild separation and only small hematoma that may not be identified, okay. So the gold standard for diagnosis in ultrasound in antepartum hemorrhage to exclude placenta previa. It's very important to exclude placenta previa. Again, here this is a retroplacental hematoma. This is the placenta which is separated, and this is the retroplacental hematoma, and this is the retroplacental hematoma. Separation between the placenta, if you compare or distinguish between placenta previa and accidental hemorrhage, clinical features and the nature of bleeding, as we said, placenta previa, painless, causeless, recurrent attack of vaginal bleeding, but here usually there is pain, and the condition may be preceded by trauma or associated with hypertension and increased blood pressure, so usually there is a cause, okay. The character of bleeding in cases of placenta previa, the bleeding almost always revealed. Once there is bleeding, it will be revealed as bright red or according to the amount of blood loss. But in cases of accidental hemorrhage, it may be concealed, revealed, or mixed according to the type. General condition and anemia. In case of placenta previa, it's proportional to the amount, the degree of external blood loss. But in case of abruptio placentae, the patient may be in hypovolemic shock without external bleeding or with mild bleeding. So usually the general condition may not be proportional to the amount of external bleeding according to the type of the or the presentation of the accidental hemorrhage. Features of preeclampsia, here usually it is not present, maybe association. Patients with placenta previa may be presented by preeclampsia. It may be present as association, but here most of cases, in 1/3 of cases, it's caused by hypertension and the elevation of the severe hypertension. Again, here compare in another way between the placenta previa and the abruptio placenta, as we mentioned before. What are complications of accidental hemorrhage or severe abruptio placentae? In complication of placenta previa, we mentioned anemia. Severe form or severe condition could be complicated by hypovolemic shock, and then from the anemia, increased liability for atonic postpartum hemorrhage, possibility for Cesarean hysterectomy, and the fetal complication. Here the condition is somewhat more dangerous, because in addition to the previous complication or the possible complication as placenta previa of hypovolemic shock, the condition may be so severe that it proceeds into acute tubular necrosis, acute renal failure. You know, acute tubular necrosis is reversible, and if it is not properly corrected, if the condition of hypovolemic shock is not properly corrected, the condition may pass into acute glomerular necrosis, which is irreversible. Okay, so the patient may be presented by hypovolemic shock, and the condition may progress if not properly adjusted or properly corrected into acute renal tubular necrosis, which is rapid replacement does not occur, and you leave the patient oligoric, you leave the patient without correction of her hemoglobin and anemic situation. The patient may pass into the irreversible acute glomerular necrosis, and in this way the patient will develop definite renal failure, and she will be kept on her life on dialysis. So this is a very important situation, and we have a patient like this in our casualty since 5 months that presented by accidental hemorrhage. She was complaining of severe preeclampsia. She developed a hemorrhagic shock. It was not properly identified, it was not properly corrected. Patient passed into acute renal tubular necrosis that was not noticed. The patient remains oligoric for 12 hours, and then she passed into acute glomerular necrosis, and she was kept on dialysis actually. Sheehan syndrome, severe postpartum hemorrhage, severe accidental hemorrhage, and severe blood loss, hypovolemic shock. If it is not properly corrected, it may result into acute necrosis of the anterior lobe of the pituitary gland, and the patient develop Sheehan syndrome. Sheehan syndrome, necrosis of the anterior pituitary. Why not the posterior pituitary? Because the anterior pituitary is low vascularity than the posterior. There is no necrosis of the posterior pituitary. There is hypothalamo-pituitary axis of vasculature. So the posterior lobe of the pituitary gland may be considered by some as part of the hypothalamus. Okay, so it carries a very high vascularity that's not affected by any hypovolemic shock unless in severe retracted cases. Disseminated intravascular coagulopathy may occur as well, which is corrected once it is properly diagnosed and corrected. Covlar uterus concealed hemorrhage may result in affection of the myometrium. The retroplacental hematoma result in weakness of the myometrium, which may be associated with severe impairment of uterine contraction and the increased liability of atonic postpartum hemorrhage. So here the maternal complication is important. Hemorrhagic shock passing into acute glomerular necrosis, Sheehan syndrome, DIC, cavallary uterus, atonic postpartum hemorrhage, in addition to the fetal complication, mean distress, IUGR, IUFD, or prematurity. Cavallary uterus. What are factors that will affect your management plan? In Placenta Previa, we said the condition of the mother, degree of bleeding. Here also the degree of bleeding is important. Any condition in which there is affection of the general condition of the mother, we will proceed immediately for active management, okay, for life saving of the mother. So the severity of bleeding is very important factor. The maternal condition and fetal condition, okay, gestational age at the onset of bleeding, provided that both mother and fetal conditions are okay, and onset of true labor pains, if my patient is in labor or not. So we have expectant management and active management. The expectant management, if the duration of gestation is less than 37 weeks, provided mild bleeding, stable general condition of the mother, good fetal well-being, and labor pains are absent. So we proceed for expectant management when the gestational age is less than 37 weeks, provided that we have mild bleeding, stable general condition of the mother, good fetal well-being, and there is no labor pains. Proceed for expectant management till reach to a good lung maturity and then terminate. Active termination of pregnancy if there is severe bleeding irrespective of other factors. Severe bleeding, immediate termination by cesarean section irrespective of other factors. If the gestational age above 37 weeks, regardless of the amount of bleeding, to terminate above 37, accidental hemorrhage, it's okay, terminate. Spontaneous onset of labor, uterine contraction, irrespective of bleeding and gestational age. Okay? If you choose the characters of your patient fit into the expectant management, what you are going to do is the same as in case of placenta previa. Hospitalization and bed rest, full investigations. Investigation is not written late. Full investigation. We are going to correct the general condition of the patient if there is anemia or whatever. Blood reservation is very important. Close observation of the mother vital signs and repeated labs if the condition of the conservative treatment takes time. Evaluation of the fetal well-being, on daily evaluation of the fetal well-being, and if the patient also Rh negative, you should give anti-D immunoglobulin of 300 microgram anti-D immunoglobulin. Active termination of pregnancy by vaginal delivery if there is mild to moderate bleeding whenever possible. Try to deliver this patient vaginal if the condition allows. Why? Because I know that this patient is liable for atonic postpartum hemorrhage. Because I know that this patient is liable to develop covulare uterus, and the covulare uterus again suffer from atonic postpartum hemorrhage. Don't add to the risk of more bleeding during cesarean section, to more interruption with contraction by the cesarean scar and the sutured uterine incision. So if we can terminate by vaginal delivery, it's okay. If we cannot, we are going to do cesarean section. خلاص. If there is severe bleeding, affect maternal or fetal condition, or other indications of cesarean, obstetric indication for cesarean section. This is the shape of the placenta and hematoma. This hematoma and this placenta. Hematoma and the placenta after placental separation. Again, cross picture of placenta and the attached hematoma, placenta and the attached hematoma. Okay, understand accidental hemorrhage, a very important topic as we agree. Again, the last, you remember, causes of antepartum hemorrhage, we said gynecologic, general cause obstetric. The obstetric, the most common is placenta previa, followed by accidental hemorrhage, and then vasa previa, the rare conditions which is called vasa previa. What is vasa previa? This is the only condition of antepartum hemorrhage in which bleeding is fetal in origin. The only condition in which bleeding is fetal in origin. Why? This situation occur when a very rare condition, okay, in which the umbilical cord vessels cross over the internal os. Why? What are the causes that make these umbilical vessels cross over the internal os? Due to filamentous insertion of the cord or the presence of succinturate lobe of the placenta. So it is a rare situation in which the umbilical cord vessels cross over the internal os. Why? When to see this situation? In case of filamentous insertion of the cord or presence of succinturate lobe. And in this situation, characteristically, the bleeding is fetal in origin. Usually there is fetal bradycardia which is unexplained with vaginal bleeding because the bleeding is fetal in origin. The fetus is bleeding. What is filamentous insertion of the cord? This is the normal insertion of the umbilical cord into the center of the fetal surface of the placenta. You have maternal surface of the placenta and fetal surface of the placenta. And the umbilical cord is inserted at the center of the fetal surface of the placenta. Here is abnormal insertion, this eccentric, okay, and this is marginal. But here it is filamentous, the umbilical cord inserted into the membranes completely away from the placenta. And so, obligatory, the blood vessels will pass in this area to reach to the placenta from and to the umbilical cord. And so, if this part is present over the internal os, the blood vessels will cross over the internal os. Another etiology, if we have succinturate lobe and the umbilical blood vessels traverse from the main placenta to the succinturate lobe to supply it. These are the two pathological situations that could elicit the condition of vasa previa. How can we diagnose vasa previa? By ultrasound, you will find the blood vessels by Doppler examination present between the presenting part and the internal os. This can be identified only by Doppler examination during vaginal, could be obstetric abdominal ultrasound. Apply Doppler, you will see these abnormal vessels. So it is diagnosed by color Doppler. If the patient develop bleeding, there is fetal distress, which is proportional to the amount of revealed blood. If you can identify fetal blood cells and the fetal hemoglobin by examination of this vaginal bleeding, and so the condition will be presented by hemorrhage following rupture of membrane, which is associated with fetal distress. And in this condition, طبعا the risk of fetal compromise, and the condition needs immediate termination by Cesarean section. This differential diagnosis of the different four conditions we mentioned before: acute placental abruption, acute condition in which there is interruption of the general condition of the patient. There may be concealed or revealed according to the type. The coagulation profile abnormal in 30% of cases. We mentioned that from the risk factor of accidental hemorrhage, thrombophilia, severe preeclampsia or severe hypertension, complicated hypertension. So in 1/3 of cases, the coagulation profile may be abnormal. The condition may be complicated by DIC as well. The fetus is normal or abnormal according to the degree of bleeding and according to the degree of separation of the placenta. The presentation in case of acute placental abruption, usually severe presentation, and the patient may be presented by hypovolemic shock. Chronic abruption, the condition is usually mild and the presentation is usually no emergency. Placenta Previa, as we mentioned, diagnosed by ultrasound. Usually the fetus is normal and the general condition of the patient proportional to the amount of vaginal bleeding, and usually the fetus is normal without any problem. Bloody show of normal labor, sometimes with the starting of uterine contraction, small amount of bloody liquor or bloody, this is not like bloody show, the plug of the mucus that close the cervix with the start of uterine contraction. This is called the bloody show. Usually everything is okay, and it may identify the onset of true labor pain. Vasa Previa, diagnosed also by Doppler examination of the vessels present traversing or crossing over the internal os. Usually the coagulation profile is normal. The fetus, if the bleeding is considerable, there may be fetal bradycardia and fetal compromise, and usually this bleeding is mild. And the mother usually is hemodynamically stable with this bleeding because it is fetal in origin. Antepartum hemorrhage of unknown etiology, this is diagnosed by exclusion. You should make sure that there is no placenta previa, there is no hypertension, there is no vasa previa. Usually it is mild, and just a close follow-up of the patient to observation, blood reservation as well. Close follow-up and observation for this patient is mandatory. The last condition is abnormally implanted or abnormal invasive placenta. It is a condition in which the placenta is abnormally implanted over the lower uterine segment, over the lower uterine segment, with the presence of uterine scar. So, abnormally invasive placenta, there should be placenta previa, abnormally implanted placenta over the lower uterine segment, and there should be Cesarean section or uterine scar, usually Cesarean section scar. And the placenta is abnormally implanted over this uterine scar. It is a rare condition and very serious and very fatal. And unfortunately, it is of increasing incidence nowadays, maybe due to increase the risk of or the instance of Cesarean section, and so fulfilling the two risk factor necessary for this presentation of abnormally invasive placenta, placenta previa, and previous Cesarean section scar. Here, this is the classification of abnormally invasive placenta. The placenta accreta. Here the placenta is just in a position with the myometrium. You see, this is the myometrium, this is the placenta. They are just very close to each other. What's normally seen during pregnancy? There should be small retroplacental hypoechoic space. Yeah, normally this is the placenta and this is the myometrium. This hypoechoic space, which is sonolucent, present between the placenta and the myometrium. In case of abnormal placental invasion, the placenta invade to involve this usual retroplacental hypoechoic space and it is absent like this, apposition of the placenta with the myometrium. So it's called placenta previa accreta. If there is more aggressive adhesion and abnormal attachment of this placenta, it infiltrates into the myometrium. Not only comes in apposition with the myometrium, no, it infiltrates deeply into the myometrium, causing placenta increta. And if there is more and more aggression of this placenta, it involves the entire thickness of the myometrium, causing placenta percreta, reaching to the serosal covering of the uterus. What is the important structure present here anterior? The bladder. Sometimes the abnormally invasive placenta infiltrate the bladder and reach to the mucosa, causing hematuria, a very critical situation that may occur even early in gestation, around 20 or above 20 weeks, and it's a very critical situation. So the classification, we have abnormally invasive placenta accreta, abnormally invasive placenta increta according to the degree of invasion of the myometrium, and placenta percreta, which is the worst type. And this abnormal adhesion could be focal, involving only part of the placenta, or could be total. The placenta in all its attachment is either accreta, increta, or percreta. So the classification, this accreta, increta, percreta, and this abnormal adhesion could be restricted to only part of the placenta or diffuse placenta invasive abnormality. Again, how can we diagnose this abnormal invasion of the placenta? It's diagnosed by ultrasound, the gold standard. Second level expert ultrasound, 2D or 3D, can diagnose. Sometimes we may need a magnetic resonance imaging or MRI. Actually, this is in cases of placenta previa when it is mainly posterior. Usually the demarcation may be somewhat problematic, and ultrasound may not give definitive diagnosis. However, even in query conditions, we should be ready during preparation of cesarean section for this patient for possibility of being accreta, for possibility of being abnormally invasive. Okay, from blood transfusion, from the expert staff that will operate upon. During ultrasound, absence of the plane of cleavage between the placenta and myometrium, and the presence of blood lacunae. Absence of the retroplacental hypoechoic space, distribution of the blood lacunae over the myometrium, even reaching to the bladder interface, and reduction of the myometrial bladder interface. Some cases of focal placenta accreta will be accidentally discovered during labor. There is a problem during the third stage of labor after delivery of the placenta, which is called retained placenta. Some cases of retained placenta are due to focal abnormally invasive placenta, which was not diagnosed during pregnancy. And according to your luck, or according to the situation, it may be separated. If it's partial and small, may be separated manually if it is accrete. You are going to produce your hand and do the sewing movement for separation of the placenta from the underlying myometrium by manual separation of the placenta. So some cases that pass undiagnosed during antenatal care and will be presented by retained placenta or delayed separation of the placenta are due to partial or focal placenta accrete. This is ultrasound. As we mentioned, there is a decrease in the bladder, decrease in the retroplacental hypoechoic space, and more vascularity in this space that may very close to the bladder, and the interruption of the bladder myometrial interface. Again here, case of placenta accreta with no plane of cleavage between the placenta and the myometrium, with more vascular lacunae. Rare cases may not be diagnosed by, as we mentioned, by ultrasound, and we may be in need for MRI, and these conditions are usually placenta previa. When the placenta is mainly posterior, we need MRI because even full bladder is not helpful in definitive diagnosis. This is a pathology, how the chorionic villi infiltrate into the myometrial cell. In the operative field, as you see, this is the DINE that's normally used during cesarean section, how the cesarean scar infiltrated by the abnormally invasive placenta, and the blood vessels are seen through the visceral peritoneum of the uterus. You see, this is the abnormal invaded placenta reaching to the visceral peritoneum. Very, very very critical situation. Again, here this is the placenta invading into the visceral peritoneum to the outside. How can you proceed for management? Majority of cases end by cesarean hysterectomy as a life-saving procedure. In cases of abnormally invasive placenta totalis, all the placenta is abnormally adherent. So the solution is to do cesarean hysterectomy. However, some cases of focal placenta accreta, and especially if the woman is young and she didn't complete her fertility potential, give her a chance of preserving the uterus and removal of only the abnormal focal part after performing all the hemostatic potentials or preparation from ligation of the uterine artery, from ligation of the internal iliac. If we necessitate, the blood transfusion should be ready, and the monitor for your procedure is the general condition of the patient. This is number one. Okay, so we can do cesarean hysterectomy, life-saving, and rapid procedure, or conservative if the condition necessitates. I hope you understand this very important clinical entity, and I'm going to take a rest and then inshallah continue the problem-based lecture. Thank you.